Thank you everyone for joining this webinar, and a special thanks to our panelists for their valued participation. As Kelly mentioned, my name is Aaron Ashton and I'm an interventional radiologist. Our goal today is to have a discussion about the COVID-19 pandemic and have the panelists share their experiences treating it on the front lines. This past year has been one of the most challenging, both as a healthcare professional and as the community. While our priority remains to our patients, as Jews, we also have an obligation to take care of our community. Since beginning of the pandemic, the Jewish Federation of Greater Dallas has been working tirelessly to meet the growing needs of our community. We have raised over $10 million towards the annual community campaign, which has allocated to organizations and agencies locally, nationally, in Israel, and to 70 countries worldwide. The Federation also has convened a community health crisis management team composed of Dallas area agencies that provide critical guidance to our community. My education about the Federation and its many programs began a few years ago when my wife and I participated in the Leadership Development Group. We spent over a year with good friends in Dallas learning about the Federation and how we as lay leaders can be involved to make a large positive impact on our own community. It was eye-opening to learn about the many facets of the Federation, from overseas support in Israel to the Chai House and the JCC here in Dallas, and even the PJ Library, which has provided us with many Jewish-themed books that I often read to my 2-year-old during bedtime, just to name a few. This year, the Jewish Federation of Dallas is one of 146 federations participating in the Human Services Relief Matching Fund. From now until December 31st, every increased or new dollar raised will be matched by 50%. So your new or increased annual campaign gift of $100 actually becomes $150. I hope you consider joining me in lighting the match. Please find the link to donate in the chat box. Thank you again for your participation and your support of our community. It is now my pleasure to introduce AJ Rosemarin, Board Chair of the Federation, to say tonight's L'chaim. Professionally, AJ has been involved in the healthcare businesses of his entire career and still has a healthcare consulting business. He has also served on the board of Texas Health Presbyterian Hospital for 7 years. AJ, the screen is yours. Thanks again.
Thank you, Aaron, for the introduction. Good evening. Back in April, we sent the following thank you out to all of our healthcare professionals. As the coronavirus pandemic continues to unfold, and as the community grapples with a new reality, we want you to know that your Federation family is thinking of you. It all starts with the efforts of frontline healthcare workers like you who are caring for the sick in our community. In the most stressful environment imaginable, you are answering the call of duty. Thank you for your unwavering commitment, courage, and your efforts in keeping our community safe. 8 months later, as this pandemic continues to unfold, these words seem more real today. Thank you for continuing to care for our community. Thank you for all you have sacrificed to keep our community safe, healthy, and able to receive the healthcare treatment we and our loved ones needed. I invite you all to raise your glass and say a quick l'chaim to all the healthcare workers. L'chaim. It is now my pleasure to introduce Zev Shulkin, one of our co-chairs for this evening's program and member of the Healthcare Committee. Zev?
Thank you, AJ, for the introduction and for your kind words. Thank you all for joining us tonight. It is my pleasure to introduce tonight's moderator and panelists. But before I begin, please remember to type any questions into the chat box. Our moderator will then read the questions during the question and answer portion of our program. Tonight's panelists are Stephen Davidoff, Lauren Fine, and Alan Shulkin, my father. Dr. Davidoff joined Southwest Pulmonary in 2005 and currently serves as an executive partner. He is dual board certified in pulmonary and critical care. He completed medical school and residency at Tulane University and his pulmonary and critical care fellowship at UT Southwestern in 2009. He has helped at local and systemic levels to develop policies for caring for COVID patients and assisted THR Plano, Allen, and Frisco develop their surge plan. In his spare time, he enjoys long distance racing, Ironman triathlons, marathons, and spending time outdoors, hiking and skiing, and with his 3 children. Dr. Lauren Fine is a Dallas native. She attended medical school at the University of Pennsylvania. She was elected chief resident her senior year, and after graduation, has primarily worked as an ER physician at Baylor University Medical Center in downtown Dallas. When she is not working, she can be found enjoying the company of her husband, Dr. Ben Morrissey, and their 2 girls, Audrey and Zoe. Dr. Alan Shulkin is a pulmonologist in Dallas and has over 45 years of experience in the medical field. He graduated from UT San Antonio in 1975. He trained in internal medicine at UT Southwestern, and he served as the chief resident under Dr. Donald Selden. He has served on the board of managers for the Dallas County Hospital District and on the Texas Medical Board. He currently practices at Medical City, Dallas. Finally, tonight's program will be moderated by Dr. Marshall Dower. Dr. Dower is currently the Regional Inpatient Care Medical Director for United Healthcare. He graduated from SUNY Downstate and completed his internship and residency at UCLA in internal medicine. He worked as an internist and emergency medicine doctor before transitioning to a directorship position. He's also a very, very important member of our healthcare committee and a big mentor to me, and he's a father to 2 daughters and 1 son. It is now my pleasure to pass the screen over to our distinguished panelists.
Oh, there we go. Hi, can everyone hear me?
All good, Marshall.
All good. All right. Well, thank you, Zev. I'm humbled and honored to be hosting this panel, and I think we'll get a lot of really interesting observations in just short order. Technical difficulties. Okay. So let's jump right in because we have a really good program. Question 1, and I'm going to open this up, but for the panelists, could you please tell us a little bit more? And again, we did have an introduction, but really focusing on your role and observations and reactions to the pandemic over the last, I don't know how many months, 8 months, 9 months, it seems like forever. We'll start with Dr. Shulkin.
It's been an amazing time. As an ICU doctor, as a lung doctor, Dr. Fine in the ER, my good friend, Dr. Davidoff, we're on the front line, and frankly, we see the worst of the worst, and it's scary. It's really scary. And it's amazing how things have evolved, how our thinking has evolved, our strategies evolved. I got a 250 hydroxychloroquine pills in my home, thinking that was going to be important back in March, and we couldn't get it, how frightened we are, how the strategy of anticoagulation has changed, how this has changed, how that's changed. And we don't know, frankly, we don't know anything. I mean, we're doing a lot of stuff and we hope that it works. And, but in terms of the reality of the science, we're still very, very primitive in what we're doing.
Dr. Fine, comments or similar?
Yeah, similar. So much has changed. A lot of people asked me what it was like in the beginning, and I said it was like if you woke up tomorrow and the Constitution was totally different. All the rules had changed, all the laws had changed. At least in the emergency room, that's what it felt like. I remember that it's funny looking back, right? Like there's a case that I may have seen back in January where the husband had been to Wuhan, but like the timing wasn't right. And they didn't think because the wife hadn't, the husband had not been sick, had come back from Wuhan. And the woman did not meet any criteria for testing because she didn't have a direct exposure to a known case. And the time frame didn't make sense. And a few weeks later, in February, it's like February 27th or 28th, I remember I peeped into the CDC, just kind of watching how things are happening. And all of a sudden they changed their definition of a case. And a person under investigation no longer had to have a clear contact with another case, and it became anyone who clinically sounded like they could have COVID. And that is when the poop hit the fan in my world. And we could no longer do anything. The next day we had, a respiratory distress patient, and all of a sudden it was, is this COVID? How do we isolate this person? How do we move them through the hospital? That patient stayed in our emergency department for 72 hours because no one could decide how to transport this person through the hospital. So we have come such a far way. I totally agree. I know so many people who stockpiled hydroxychloroquine. Our intensivists and the pulmonologists on here can speak to this, but in the beginning, everyone was getting intubated. If you required 6 liters of oxygen, everyone got intubated. You were intubated in order to move upstairs, whether you needed more support than 6 liters or not. There was a lot of questions about aerosol. There was a lot of fear. There was a lot of not going into rooms if you could at all avoid it. And we are in a different world today, fundamentally, right? We have some things that we know. We have a better sense of what we're doing. We have systems in place. We've all figured out our triage processes, both up front in front of the emergency department or in the ER, but also in the hospital. It's just, we're finally used to the new constitution. So it is a brave new world that we're in at this point.
I'm struck by how much we've had to learn and how much we have learned in what seems like forever, but really a relatively short period of time. Dr. Davidoff, I'm interested in your observations, which I'm sure are extensive and probably mirror those of our other panelists, but please go ahead.
Yeah, thank you. I would say, the biggest thing in the beginning was the unknown. Lauren, you're correct. I mean, we were intubating a lot of patients. For us, it was if you hit 10 liters, you moved to the ICU and you got intubated. I can tell you, I had the first death in Collin County. And there was so much fear just entering the room, the unknown. We weren't wearing N95s. The hospital didn't let us wear N95s. You thought, this doesn't sound right. This sounds like it's an airborne or, a combination of disease states where it's both droplet and airborne. What do I do? The patients don't know the questions to ask. They're fearful. The nursing staff was fearful. My role as the medical director of our 3 ICUs was to help work with the hospitals and develop a surge plan. And we came up with this elaborate surge plan, like many hospitals, where we were going to shut down our recovery rooms. The recovery room nurses were going to come help us. The anesthesiologists were going to help man the anesthesia vents. We got training on how to use the anesthesia machines, which I've never seen, which Alan will tell you, they're nothing like our traditional vents that we're used to. And then that surge and feeling of being overwhelmed never happened, which was great. It's a very different feeling now. Clearly, we've learned a lot about the disease. We've learned some drugs work, some drugs don't. I mean, we gave hydroxychloroquine to everyone, and it didn't really do anything. Now, obviously, we're getting remdesivir, steroids, and anticoagulation. I think that it's real-time science. No one wants to admit it, but we're experimenting and learning science in real time and every day. I think you went from medical staffs that were very fearful in the beginning, where people wouldn't go into rooms, people didn't know what to do, they were really at risk. You were coming home, stripping off your clothes, leaving everything outside before you came in, to now, I'm not so worried about contact. I don't wipe down my groceries. I'm still nervous when I intubate patients, but 8 months into the pandemic, knock on wood, my partners and I and critical care docs and ER docs have, for the most part, avoided the disease using, PPE. Now the times are a little bit more stressful, and as I'm certain we'll talk about later, there is a surge and there's a shortage of both beds and nurses, and it's a whole different set of problems right now that we're dealing with.
Yeah, so, the public has reacted just as medical community has. And I know we've all heard about people avoiding medical care. And I think the emergency room is the front door of the hospital. And Dr. Fine, I'm sure you've seen sort of changes in how people are accessing medical care and, delaying and, seeking care. Could you comment on, people coming to the emergency room and, what you've seen and what you would advise people to do in this current setting?
So right after COVID happened and everyone said, stay home, literally everyone stayed home, right? Like no one came to the hospital. If you came to the hospital, it was because you were dying. And that was, I think, a side of the pendulum no one expected, right? Like no one expected that people would stay home when they had a major stroke or when they were having crushing chest pain, but they did, right? Like nationally, the number of people presenting with acute MI went down like 40%. So there was this very weird quiet time in the early days where we both had, the fear of the small number of people presenting who were sick with COVID, but then we just had no patients. I mean, our volume dropped 30, 40% initially. We're still probably about 20% of our normal volume, although I would say that we've adjusted our staffing. So it's interesting because I think a lot of lay people think, oh, the ERs have been crazy the whole time, but really the ERs, we all had to cut our hours. And most of us took huge cuts in both our pay and our just work schedule because there weren't patients. So that has changed and it is coming back, which is good. I think people realize now that, hey, if you wake up and you can't move half of your body, you should probably go to the hospital. And then with COVID, I think what's changed is that really, right, that early messaging about stay home was kind of like, the intention was to tell people with mild COVID symptoms not to come to the hospital because there was nothing we could do and we were going to send them home anyway. And I think what's different now is that we're actually telling people with COVID, hey, come in if your symptoms are mild and you're high risk, right? Because at least at BUMC, and I think many other hospitals, we now have access to these monoclonal antibodies that are specifically indicated for people with, early disease who are not sick enough to require hospitalization, but who might be at risk for progression of disease. And those people are going to benefit from these treatments. We are telling them to come in now. My 5-year-old is showing up to participate in the Zoom talk. Oh, both of my children. Sorry about that. Sorry.
It's Zoom.
What was I going to say? So that's changed, right? Again, like we are all learning and adapting that in the beginning we said, hey, stay home because there's nothing we can do for you. But now I'm telling people, hey, you are over 65 or you are a diabetic or you have some other problem, you're obese and you have early mild disease, come in because we have things we can, with some data, that we can do for you. And then you can go.
And indeed, we do have things, remdesivir, dexamethasone, monoclonal antibodies, and the timing is so important, giving it to the right patient at the right time and not too late is really crucial. So that's great information. So, unfortunately, people are focused on the mortality, but there's a lot of morbidity. And I know Dr. Davidoff and I assume Dr. Shulkin too are seeing some of the long-term effects. And, there's different names that have gone along with this, long haulers and long COVID and chronic COVID and post-COVID. That's a big concern. It's easy to focus on, 280,000 deaths. But I think what we also need to be aware of, and I'd be interested in your comments, are the morbidity and the sequela of the disease. I don't know.
Sure.
Yep.
So we're certainly starting to see patients that we saw in the hospital back early on in the pandemic. Those that were intubated may have received plasma, remdesivir. This Longhaul syndrome it's a very bizarre disease, and patients seem to have this unusual constellation of symptoms. Most commonly, patients are short of breath. They may do pulmonary function studies and their PFTs may be normal, but they're still short of breath. They may have chronic fatigue. They may have headaches. And then another unusual symptom that we're seeing right now is what's called POTS syndrome, where patients' blood pressure, they just get dizzy. They stand up, their blood pressure drops, their heart rate drops, and there's all these unusual long-term side effects in addition to blood clots that we've seen. I've also referred, and Alan, I'm certain you've probably seen this as well, at least a handful of patients for lung transplant evaluations that have come into my office 3 months after COVID. They're still on 4 or 5 liters of oxygen, and their lungs have been literally destroyed. They look like someone that has pulmonary fibrosis. And we don't understand why some people are attacked so severely to this disease and some aren't. You know, I think that's where science is still lacking to give us better predictors of who may have Longhaul syndrome. Why do some people develop pulmonary fibrosis? Why do some patients' lungs collapse and have this sequela of disease and others don't?
No, and I agree too. The unpredictability of who's going to get sick, and the variability, and the people with premorbid conditions, people who they could not do worth a darn and have no problem. Healthy people like a respiratory therapist of ours who was wonderfully healthy is now dead after 6 weeks. It's horrible. A woman that I have who was awaiting a lung transplant, I didn't think there'd be a shot in hell that she'd survive. She did, but she's devastated. Now she's too sick to be transplanted. So it's unpredictable, as I said before, both from the beginning and at the end. People bounce back and they're great. And as you comment, some people just suffer and suffer and suffer in an absolutely, and I keep using the same word over and over again, in an unpredictable way.
So I think we've gotten into, how the treatment has changed. We have more tools and, more effective and now proven therapies. It's been a little rough go. I think the urgency got ahead of the science, and preprints got ahead of peer review. But I think every physician in this who's been taking care of patients has basically become a scientist by dint of necessity. So, Dr. Fine, one of the things we focused on, and a big push originally, is testing. And there's all different forms of testing. We've learned about PCR and antibodies and antigen testing. Could you comment on the role and how testing and access to it, and how it has been used and how it perhaps should be used going forward?
I think testing has gotten better, and access to testing has gotten better. I'm still waiting for someone to invent the $2, $5, $1 home test, right? That is so cheap that you can take it every day and you can use it in real time to make decisions. And that's the biggest limitation of these PCRs, right? Is that, like, for many people, I mean, I haven't kept track of it, but our hospitals still take 7 to 9 hours in general for our average PCR. We have limited access to some of the faster PCR tests. In the community, I wouldn't be surprised if it's still taking 72 hours to days, right? And that's just, like, not helpful. I mean, that is just a plain old not helpful test most of the time, because it's too late. By the time you get that information back, you've already exposed a bunch of people. You're probably less infectious, and I mean, the cat's out of the bag. So I find that really frustrating. The antigen test is certainly faster, maybe a little bit less accurate all the time, but it's, at least it gets you a result quickly, and when it's positive, it's pretty good. If it's negative, who knows? But God, I don't know. We're just not there yet, right? We don't have the testing we need. And I know there's several companies that are still working on these kind of home point of care tests, but we don't have them yet. That's what I'm hoping for.
Lauren, are y'all regularly tested? Or Alan?
No.
Neither are we. Just for our panelists, as a critical care doc, you would think that we get tested. I've been tested once in May when I thought I may have symptoms. I had a couple days of GI symptoms, some night sweats, and it was a challenge in May to try and get myself tested. But we're routinely not tested, and most members of our medical community are not.
And you guys at Presby, y'all are all your tests are the Cepheid, like 1 hour turnaround PCR sort of thing?
We do, but we also have the send out that we'll send out to UT Southwestern or Presby Dallas for the more sensitive PCR. So if someone tests negative and we have a high suspicion of disease, we have the ability to do a send out either to Quest or to Presby Dallas or to Southwestern, depending upon who's got availability, to have the more sensitive PCR testing to be able to be run. But that's a 24-hour turnaround still.
You know, I think there's also a lot of talk, I'm curious what your all's thoughts are about the non-standardized cycle threshold cutoffs for all of these PCRs, and that, you know, are some of these tests overly sensitive? And I don't have a sense of if anyone in the States are trying to standardize cycle thresholds or looking at serial cycle thresholds to maybe determine where in your infectiousness you are. Have you guys done much thinking about those issues?
We have not, but clearly there's a multitude of tests, right? The FDA, out of necessity, approved almost every test that came to market because we've had such a shortage. I mean, my hope is in the coming year that we will have more standardized testing. We'll know which tests are better than others, which tests are more sensitive, which tests are more specific, and be able to compare. I still think there is a big dilemma for patients that are trying to get tested. I drive by a rapid COVID testing center around the corner from my house on the way to the hospital. That's my rough sense of how bad things are, is how many cars at 7 in the morning are parked in line. That tells me we're still, you know, most days this week, there's 100+ cars waiting in line at 7 in the morning. That tells me we still don't have the amount of tests that we need to accurately understand, you know, the spread of this disease.
I see that we've lost our moderator and that there's a question. Does someone want to take on this question? I can do it. Someone else can do it.
Go ahead, please.
I have a question. Marshall dropped off. How should other doctors be safe? Should we keep practicing in medicine? How do we do this? In other words, what are the precautions we should take in our offices? I know everyone tries their best to be safe and keep patients separated and keep distancing, and we try to operate the best we can. But I mean, we have positive tests all the time. So the question is, what's your advice for us to stay safe?
So I'm happy to answer that. So we routinely see patients in the office, and so I will answer the question from Kelly as well. I think it's safe to go to medical practices. I think that we have seen, since universal mask wearing, I think we've seen a significant reduction in healthcare associated transmissions. What we know from states that implemented mask wearing, you know, the amount of cases dramatically went down. When you look at sort of the anecdotal evidence, no one's really looked at in physician offices, but you have the studies, the observational studies that were done in salons where you had, you know, someone that tested positive, but both people were masked. You know, 97 to 98% of those patients, or people that came, I say patients, people that came into the salon tested negative. So if you are wearing a mask and your provider is wearing a mask and both of you wash your hands, I think there is a very limited chance, you know, less than 1%, I would say, of contracting the virus. That would require either you or the physician to be testing positive. I would tell you, and Zeb, from our perspective, we now, since the incidence of disease is high, we wear eye protection for every patient that we see. I'm wearing, you know, a shield. If we're doing, and Alan, I don't know if y'all are doing PFTs in your office, when we're doing breathing tests, we're testing our patients with rapid antigen tests prior to doing a breathing test. But I think that it is safe to, you know, seek medical care at this time, simply because of the precautions. Everyone's getting temperature checked prior to coming into the building. Everyone answers a screener. Again, that doesn't do anything for the asymptomatic transmission, but that's why everyone's wearing a mask. wearing a mask helps prevent asymptomatic transmission from one provider or one patient to another.
I 100% agree. I'm a big fan of universal precautions. We all live in, it's supposed to be at least a surgical mask, as long as someone doesn't, quote unquote, have an aerosolizing procedure, and then eye protection, which I'm just going to go ahead and act like an advertiser for this company. But for those of you who have prescription glasses and don't like wearing contacts, there's a company, I mean, there's a bunch of options out there now, but there's a company that makes a 3D printed clip that can slide onto your onto the bar of your glasses called Clip 19, and then you can get these refillable plastic shields that clip on, so they're like attached to your prescription lenses. There's no extra stuff going on your ears or anything, and they're really tall, so they like really cover your whole face. They also like keep you from touching your face, so helpful. I personally live in an N95. I will say a part of COVID fatigue in my department has been the number of providers who have stopped wearing N95s all the time, which certainly aren't required unless we are doing, aerosol generating procedures in theory. However, personally, I just feel more comfortable in one, and that's not to say I get a new one every day. I'm using the same. I've had probably 10 now since the beginning of COVID, and I cycled between them. I sort of did 5 for the first however many months, and then I got a refill of 5, and I've been cycling through those. And, maybe the seal isn't quite as good as it was in the beginning, but I like that it feels safer. It covers things evenly and somewhat is close to my face and makes me feel like I'm probably safer, because I'm also around a lot of patients who can't mask or won't keep their masks on. So that's my personal default. And I mean, I think masks work. So mask and face shield. I feel frustrated by the gowns, I have to say. Like, I know it's a part of the CDC recommended package, but in the early CDC guidance on what was considered like a low, moderate, or high risk exposure, whether or not you had a gown on did not change the CDC's level of risk exposure. And so while we're doing that, I don't personally feel like that's the most bang for your buck.
I would add one other thing. I actually I wear an N95 in clinic. I'm more concerned when I see patients in clinic than I am in the hospital, because in the hospital with the electronic health record, I can look at every vital, I can look at their labs, I can look at their x-rays, and I can assess everything prior to going in. When a new patient or a patient's coming into clinic, I have one set of vitals. And so I certainly wear an N95 in clinic. I feel like there's no downside to wearing an N95 other than some marks under my eyes.
Yeah, and to that, all of my, I was gonna say, all patients are undifferentiated. So like yesterday, two days ago, I had a person in a car accident who came in with a big head wound and, needed scans for his car accident, had multiple traumatic injuries. Oh, and guess what? He also tested positive for COVID. And in the beginning, this was crazy to me. It was like, oh my gosh, this person with appendicitis has COVID. Now it is like everybody and their mom has COVID. And it's just not even surprising anymore. It's just like, okay, another person who has COVID and had no idea.
Thank you so much, guys. I'll hop in for Marshall until he's able to join us. We did have
I'm on, if you can hear me.
There you go.
I have 2 computers and a phone, crazy. So, I think we've talked about the sort of protein manifestations. Can you hear me still?
Yes.
And unpredictability, which are the sort of the hallmarks of this disease. And some of this is very theoretical, and I've been reading articles about interferon antibodies and lack of interferon, and some of it is what we figured out, and some of it we're still learning. I mean, why would you, and some of this we know, why would you speculate as to how and why people are affected so differently by the virus? Some of it, I think Dr. Shulkin touched on. People who you'd expect to do poorly sometimes don't. People who you expect to do well do poorly. We all become humbled in medicine. We've heard about the comorbidities that put people at risk. would you guys like to comment on that in no particular order? Maybe start with Dr. Shulkin, though.
And not a clue. I'll defer to our epidemiology colleagues. I have no whatsoever. I use the word, and I don't want to be redundant, but I'm being redundant. It's who's going to get sick. I mean, really sick. And among those who get sick, who's going to get well? Absolutely. It's Vegas.
I will tell you, in terms of those that get really sick, those that clearly have metabolic syndrome, the ones that we've seen, the most complex cases that have had poor outcomes, morbidly obese, diabetics. High blood pressure is listed. I don't see high blood pressure as the biggest comorbidity. Of the patients that we see do poor, it's the diabetics that are uncontrolled, and then obesity. And I'll be honest, we see a lot of Hispanic patients that have done very poorly. And I don't know, that is a question, Alan, you're correct, for the epidemiologist to answer. Is it sociologic? Is it epidemiologic? Or is this genetic that they're predisposed? I have a feeling it's probably a combination, but those three things have been the factors that we've seen that have had worse outcomes.
And I think your comment demographically is very interesting, because I think the initial surge, March, April, everybody was getting sick, no matter racial, sex, gender, everybody. The summer illness, the summer surge seemed to be more, it became a poor person's disease. It became a disease of the working person, of the Hispanic person, and we weren't seeing it in the upper middle class folks. Now it seems to be the surge is recurring once again. Now, granted, I'm not living in Williamsburg or in Brooklyn, but there has been a demographic change, I think a fairly dramatic one. And I suspect it's the world in which many people live, the amount of information, the ability to protect, the ability to isolate, the ability to it's just like tuberculosis 70 years ago. The great reduction in the incidence of TB happened long before there was INH. Living conditions, how people associate and congregate with one another.
Mouse. So fortunately, I think we've done a good job with PPE and shielding. But I heard Dr. Shulkin say that he lost a respiratory therapist on his team. We're hearing about certain areas that are overwhelmed, and they're talking about having people who have tested positive and maybe are still sick still coming to work. So how are you handling someone on your team testing positive, and the whole issue of difference between quarantining and isolating? I mean, certainly the workforce is at risk. How are y'all handling that? Because that's a major problem. We don't want to imperil our healthcare workforce yet. That's really an issue. I don't know, Dr. Fine, do you want to jump in? And you're
sure. I mean, we actually haven't. So as Dr. Davidoff alluded to, I mean, our staff has mostly been okay. We really haven't had many infections among our, certainly among our physicians. I get the sense that the cases that have happened that I know of in our emergency department are not from within the department. I suspect they're from outside. We still have a policy that if you test positive, you have to quarantine. We do not currently have any plan in place that people should work with COVID. I can imagine a world in which that could happen, and we might be there, by the end of this month. I think it's possible. That's not based on anything I've heard. I can imagine it, but we're not there right now. And it's interesting, I don't think it would be wrong to have people with, let's say, a positive test and really mild symptoms work, as long as they were wearing a highly protective, mask the whole time and following all the PPE guidance. It'd be hard for me to imagine that a minimally symptomatic physician wearing an N95 and a face shield has much of a chance of infecting anyone. So I could justify it if it needs to happen, but we're not there yet.
No. And I hate to use the word easy, but we have a couple of things that probably bear a discussion that actually we actually do have some good answers to, I think, but I'd be interested in your comments. So here's one that I think we have a pretty good understanding, although long term, I think our knowledge will evolve. So Dr. Davidoff, would you comment, is it possible to get COVID more than once? Yeah.
In theory, yes, it's possible to get COVID more than once. There's been a handful of redocumented infections. I think over the next 6 months or year, we're going to have a much better understanding of that than what we have now. No one really knows how long immunity lasts. 3 months, 6. The Moderna study, just released that they've got antibodies still at 6 months. The question is antibodies the answer to look at, or T-cell immunity? The bigger question. I have several friends, as well as I have a colleague, back to your other question, testing positive. One of my partners has tested positive, never knew it, found out via donating blood that he had antibodies. So he clearly worked when he was an asymptomatic carrier. I think that, there've been probably 5 to 15 redocumented infections worldwide. So clearly it's possible. I think that it's going to be very rare, at least in a 6-month period. There are some folks that get influenza twice. Obviously, there's influenza A and influenza B. So there are different strains of COVID. I think you'd be very unlucky. And clearly the numbers of, when you're talking 15 million plus cases just in the US, we've had 2 or 3 redocumented infections. So at least in the first 6 months to a year, I think that there's a very low likelihood. After a year, it's anyone's guess.
Yeah, I think
in my own personal experience, I've seen 2 reinfections, and it worries me. Documented negative, and then documented infected, documented convert to negative, and 4 months later positive again.
Wow.
One happened to be a stem cell transplant person, so that's a very altered immune system, if you will. And one is a woman that I treat and was clearly negative, ill in June, negative in July, positive now in November.
Yeah, so back to Dr. Shulkin again. So this one, I think we have a good answer to, and sort of a myth in the community, and we certainly want people to do this. Are there really any negative effects to wearing a mask on the person wearing the mask?
Well, I'll ask the young Dr. Shulkin, because I can't wear my contact. That's the only negative. No.
The one thing we can definitely say, please wear a mask. It won't harm you. You're not going to get hypoxemic. You're not going to have a problem. Even if you have lung disease, wear a mask. So
my patients with COPD come into the office wearing oxygen, wearing a mask. They do just fine.
one softball in all of this. So let's go to something really positive. We're going to maybe, with our last question, end on a positive note, talking about the vaccine. And remarkably, our timing is great. Hanukkah is in a couple of days, and the FDA meets tomorrow for Pfizer, and they meet on the 17th for Moderna. So I think we're going to get a unanimity on this one, but I'll throw this one out there. I maybe would phrase it when, but I'll phrase it, are you planning to get the vaccine? I know there's the prioritization with frontline physicians being 1A, but are you planning to get a vaccine? I think we'll get a unanimity on this, but we'll see. And the further question is, and this is going to be interesting, and it goes to availability of the vaccine and uptake of the vaccine. How long do you think it will take to be widely distributed? A lot of logistic issues there. So I don't know, maybe we can start with Dr. Fine, and we'll go down the panel.
I'm super excited. Getting it. Not come soon enough.
Yeah.
I'm pretty excited about that recent data that was released that shows that even at 10 days post the first shot, it looks like there starts to be a protective effect. Yeah, I'm excited about it. So I think I think we're going to be getting it next week. I assume Presby the same. And, you know, I'll be really interested just to see if people take it. I think we were sort of talking about this before the panel started, but there's shockingly a surprising amount of vaccine hesitancy, even among medical professionals, that I find sad. But there you go. And when do I think we're going to start to get to like everyone, like normal, healthy people getting it? I'm going to guess like 8 months. I feel like that's sort of around what I've heard, maybe.
Yeah, I think, you know, unfortunately, we may not have bought as many doses from Pfizer as we would have liked. I think it depends upon, you know, production, and then the logistics, and then, you know, whether other vaccines get online, the AstraZeneca, the Johnson & Johnson. I've heard a lot of people say that, you know, it may not be the best vaccine, but get any vaccine once it passes the FDA. I don't know, Dr. Davidoff from Shulkin, any comments from you on the vaccine in the offing?
My patients are literally begging, how do I get on the list? How do I get prioritized? And, you know, and so I've encountered very few people who are skeptical about it. And of course it will be. And I've not encountered any colleagues yet who are skeptical. We're kind of trying to walk on glass to get it, if you will.
So I'll echo what Lauren said. The FDA yesterday released their data dump of the Pfizer vaccine. The data from it's really impressive. In fact, more impressive than not. I know there's been a lot of comment, Marshall, you alluded that we could have bought more Pfizer vaccine. I actually don't think that that's that big of a deal. You know, when they had the opportunity to buy, it was in phase 2. You still had very small studies. We, as a country, have purchased AstraZeneca, Novavax, you know, 200 million of AstraZeneca, I think 100 million of Novavax. So the answer to your question, I think I've been told that I'll get a vaccine sometime between next Wednesday and next Friday. I'm personally very excited about that. It certainly makes me feel a little bit less nervous intubating patients. I think the question to how long it's widely distributed, I actually am more optimistic. My mantra in this that my parents helped give me was faith, not fear, faith in the science, faith in PPE, and faith in the guy upstairs. I think it's going to be April or May. I think that in December, I think that the end of this month, in January and February, I think AstraZeneca vaccine will get approved. J&J is due to release their data early January. They've completed enrollment in their phase 3. Novavax, you saw this past week, the Chinese released data on their vaccine, and their vaccine, you know, is 84% effective. There's 21 different vaccines in clinical trial. We're clearly going to have multiple other vaccines that work. Just Moderna and Pfizer were the first to get to where they are. So I'm hopeful it's April or May, not 8 months.
Yeah, so a good positive note. And one other thing we might touch on, and you know, I think there's probably innumerable things. Certainly, we can be extremely proud of the way, you know, our community has reacted, our medical community, locally, nationally. Can you focus on or highlight one instance, and I'm sure there are many, where either you or your team members or people that you're aware of have stepped up or done something unique, something that you're uniquely proud of during this time?
Does just working count? I'm going to go with working clinically. Right? Like, I really think that everyone who still came to the hospital and didn't quit is a hero. I mean, I did not live through the AIDS epidemic, but I have heard some stories, and the beginning, this was really scary. I've young kids, and, you know, came home to my husband, who's also an emergency room physician, and we had to have this talk of like, okay, if both of us die, what happens to the kids, you know? And that is every healthcare provider everywhere, right? Like, all of us thinking about our families and what are we bringing home and how infectious is it and how do we so going to work was a leap of faith. And I applaud everyone in every role, from physician to nurse to environmental services, the most overlooked employees of the hospital, who are true heroes for going cleaning every room after every COVID patient has been in there. They're all heroes.
Yep. Well put. Thank you. Dr. Davidoff or Shulkin?
Sure. So I would tell you the ingenuity and teamwork have just been absolutely unbelievable. I'm very fortunate to partner with a great healthcare system in Texas Health Resources. They basically asked us, what do we need? And they gave us carte blanche to redesign the intensive care unit, equipment, testing, whatever we needed to support us. And 3 different hospitals, all came to my group with, well, what is your surge plan? And we said, there's 6 of us. You've got 3 different hospitals. We're going to need backup and support. We will oversee and triage and meet weekly. And just the amount of teamwork is absolutely unbelievable. Lauren, I'll echo your comments. I mean, I came home scared. I rewrote a will. I was fearful of dying in the beginning. Now not so much. But simply the teamwork that was there early on in the community, the folks that were sending lunches and meals. I had a bunch of friends, some that are on this call, that signed up for meal trains for the nurses, said, what do I need? I said, I don't need anything, although some did drop by toilet paper early on. Just the collegiality that everyone has engaged in, that's really what I'm most proud in, is because healthcare systems really, they were left to fend for their own. There has not been a lot of, without being political, there hasn't been a lot of top-down national leadership, and so local systems really had to fend for themselves. And you saw that the HCAs and the Presbys and the Baylors, that those systems that had strong leadership in place, they've been able to handle the surge, and they've been able to be prepared and not run out of PPE, and all the things that we've seen have been really quite miraculous.
Yep. So we're heading to the end, and I don't want to shortchange our other speakers. Couple of questions have come up. One I'll answer quickly, and I'll throw the other ones out to the panel. Someone noted that they're noticing death certificates having COVID, even if the cause of death wasn't, death certificates, vary legalities. I know Dr. Shulkin is the expert on the board, but every state has sort of different requirements in filling out death certificates. But certainly we've seen, unfortunately, and I think Dr. Fine touched on this, a spillover effect, people delaying coming in. And even though COVID maybe wasn't the proximate cause, it certainly has had an effect on people delaying care, and we may see other things later on in terms of people, getting congestive heart failure from untreated MIs and all other things, and delaying care, cancer screenings, etc. A lot of people in our community have stepped up. I know a number of people who've been in the studies. One of the physicians has been in the Moderna study, and someone else asked a question: is there value in getting more than one vaccine since they work differently? I have an opinion on that, but I don't know if any one of our panelists wants to weigh in on mixing and matching vaccines. That's been a couple of questions in that regard.
I think you run the risk of overstimulating your immune system. The Moderna and Pfizer are certainly similar. They're both mRNA vaccines that target the spike protein. Hasn't been tested. I certainly, one of the questions I see, is there an advantage to taking different vaccines since they work differently? The answer is we don't know. I think next year you might know the answer to that, but it may be 2 or 3 years down the road, and then you'll have head-to-head trials of one vaccine over the other. But I certainly wouldn't mix and match, because the mechanisms are slightly different. And I would take what we get, which is certainly a lot better than nothing, and 90+% protective. Again, in the setting of wearing masks and still social distancing, is a huge win to try and get us out of this pandemic.
Yeah. Anyone else want to weigh in? Yeah, I think the other thing is, although the vaccines are great, people need to do all the other things, for a significant period of time. Don't throw away your mask, not physical distance, take all the precautions that you're taking, because you're not going to have herd immunity for a while. Moreover, vaccines are not 100%, and you really, with the 2 vaccine series, you really need to get that second shot. So I think we've done a great job staying on time, which is remarkable given the complexity, and with 4 physicians talking, this is almost unheard of. It's really been great, and I think I could go on all night. But I think at this time I'm tasked to introduce Miriam. So Miriam, if you want to go ahead, and I think you're on.
Thank you. For those who don't know me, my name is Miriam Shbeen-Feast, and I am the president and the CEO of the Jewish Federation. And I am looking at the remarks that I had prepared before this panel discussion, and have to say I'm going a little bit off script, just to say that this was incredibly informative. And you are right, Marshall, Dr. Dower, you are quite right that in the time that we had, the information that was shared is incredibly invaluable. I heard Dr. Davidoff a couple of months ago as he was speaking somewhere else, and it was sobering and in some ways scary, as he had mentioned, and I believe that Dr. Fine and Dr. Shulkin had mentioned how months ago the information was different than it is today. I found this, and I hope all of you did, informative, somewhat encouraging, and reminding everybody, obviously, masks and social distance is needed and necessary. And I also just want to add, as you had pointed out, Dr. Fine, how your colleagues, you applauded their leap of faith and those who came to work every day. I want to say on behalf of the Federation, we applaud our panelists, your leap of faith, your leadership, your showing up. You are truly frontline heroes. You are men and a woman of valor, and we thank you. And although not the same at all, we all have an opportunity, especially as Hanukkah approaches tomorrow night, to be community heroes. If I want to reiterate what Aaron shared with you earlier tonight, if you have not, please consider making your pledge to the 2021 annual campaign. And I hope that if it's a new gift, or if it's not a new gift, but it's an increase to that gift that you gave last year, or if you've already made a pledge to the 2021 campaign, consider making an increase, because that gift will be matched 50 cents to the dollar. And I hope as we are lighting our candles tomorrow night, that we together also light a candle for our community during this very dark time. I thank you all for joining us. I thank our panelists. I thank our committee, Dr. Dower for your facilitating, Dr. Shulkin, Zev Shulkin, for helping put this together, and for your introductions, to AJ Rosemarin for your wonderful welcome. And I wish you all a Chag Hanukkah Sameach. May you have a safe, a healthy, and a festive holiday. Good night.